This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Hi, everybody. This is Tony Tarchichi here. Before you listen to the podcast I recorded for you, I just wanted you to know I had a little trouble with the audio for this podcast. I did my best. I couldn't get it exactly the way I wanted it. So I did want to take a moment to say I do apologize for that. I'll try and keep getting better at this as I go forward. Enjoy the show. All right, welcome everybody to PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. We are still coming to you from UPMC, Children's Hospital of Pittsburgh. I am still a MedPeds trained pediatric hospitalist here at the Paul C. Gaffney Division of Pediatric Hospital Medicine. As a reminder, we continue to offer free CME credit with every podcast courtesy of the University of Pittsburgh, so thank you, University of Pittsburgh. To get it, all you have to do is click on the link at the bottom in the podcast description. You're going to be required to create a login, answer some questions that I write, which are not that hard, I hope. And then you get your free CME credit. That's all there is to it. So, today's episode is going to be on acute gastroenteritis, which is, again, part of the American Board of Pediatrics content specifications for pediatric hospital medicine. I am fortunate enough today to have as my guest Dr. Arvind Srinath, MD/MS, who is an associate professor of pediatrics here at the University of Pittsburgh, associate vice chair for education for fellowship training in the Department of Pediatrics here at Children's Hospital of Pittsburgh. He's a pediatric gastroenterologist, and he's a pediatric gastroenterology fellowship program director. He got his undergraduate degree at Hopkins, medical degree from here at the University of Pittsburgh, and then did residency at Johns Hopkins, and did the GI fellowship here at Children's Hospital of Pittsburgh at UPMC. So he also has a Master of Science in Medical Education through the University of Pittsburgh. So I really wanted to say thank you very much, Dr. Srinath, for coming to join us today.
Thank you for this opportunity, Tony.
So now, Arvind, we're going to go through all of acute gastroenteritis, but I thought a good place to start is just some basic definitions, just so we're all talking about the same thing, and the people at home who are driving or exercising, whatever it is you all do, when you listen to me, you know what we're talking about. So the first most basic definition is diarrhea, because people kind of throw it around, and it's nice to know what the definition is. And I got this from the WHO, and what they define this as passage of 3 or more loose or liquid stools per 24-hour period, or more frequently than is normal for an individual, is diarrhea. And they go in this to say, for an infant, passing of loose pasty stools for breastfed infants is not diarrhea, even if the frequency is increased. Is that what you all use in your field as the basic definition of diarrhea?
Exactly. I think the key point is there are volume quantifications for diarrhea, but particularly as folks get older, the significance or utility of those gets lower and lower.
Okay. Now, just for you guys listening at home, I'm going to start out by going through a couple of major articles. The first one is from one of my favorite journals, Pediatrics in Review, from November 2012, Acute Gastroenteritis, by Denise Granada-Villar et al. That was volume 133, number 11. The next one is the 2017 IDSA, Infectious Disease Society of America's Clinical Practice Guidelines for the Diagnosis and Management of Infectious Diarrhea. That was published in Clinical Infectious Disease in 2017, so very recently. The authors are Andy Shane et al., and this was very comprehensive, so we're going to kind of walk through that. But to round out the definitions part, they actually have 4 definitions for diarrhea. So acute, watery, or bloody diarrhea, they define it less than 7 days. Then they talk about prolonged diarrhea, 7 to 13 days. And then persistent diarrhea, 14 to 29 days. And chronic diarrhea, more than 29 days. That's a lot of definitions. It's 4 categories, just seem to me like a lot. Clinically, how useful is it to have those definitions broken up that specifically?
I think it really depends on how much you're thinking about etiologies for these diarrhea.
Okay.
So, for example, it's easier to broadly define these diarrheal categories as before and after, shorter or longer than 14 days, because then it's really helpful to differentiate infectious versus non-infectious causes. However, I really appreciate how they stratify it to really differentiate, namely the infectious causes with the stratification at 7 days.
And since we're talking about acute gastritis, we're primarily doing it under 7 days, and the overwhelming majority of those are going to be infectious.
Exactly.
And then they broke down, which I want to bring up early, some of the epidemiology, specifically what was and what is the most common causes now of acute gastroenteritis in kids. They brought up that it used to be rotavirus was the most common cause. And then now, since the rotavirus vaccine has been reinstituted after there was all of the intussusception associated with it, the first one, and now this one that's working so well, it's no longer. Now we have norovirus is the most common pathogen in children under 5 years old causing gastroenteritis. Now, what was interesting to me was that it doesn't seem that noro is as potent as rota used to be. So looking at the numbers, rota used to cause about 3 million annual episodes of acute gastroenteritis, over 500,000 outpatient visits, 27,000 hospitalizations, and 25 deaths. Now, norovirus causes about 1 million ambulatory visits, so about a third, and 14,000 hospitalizations annually. So about half of what rota did. So noro, while it's a problem, isn't as big of a problem as rotavirus was. Is that right?
Great, completely agree.
Because I remember in the old days, lots of community hospitals had children's floors or children's sections, and they were always full in the winter with diarrhea and vomiting and RSV. And now since rota is really going out of the way, a lot of those have closed. And it makes sense now looking at what noro does. And then for bacterial pathogens, again in kids under 5, the most common is Salmonella enteritica subspecies, then followed by Campylobacter, Shigella, Yersinia, and E. coli. And that's kind of what we have seen on the hospital medicine service. Now, Shigella, we may have seen a little more because there was a couple of outbreaks in Allegheny County, which is where we're located, but it seemed right to me. So when they talk about these guidelines, the first thing they talk about is what you have to look for in the history and physical. And what you want to look for in the history is if the person's a caretaker, whatever that can mean, daycare, long-term care facility for older adults, or preparing food if you have, and then ask those questions in the history. It made sense later in the guidelines where they focused on it because of certain pathogens, specifically Salmonella, are the ones that cause, the bacterial ones that may cause bloody stools, or especially the ones that cause typhoid fever. We have to know what that person does to know what your local health care or public health guidelines recommend, whether or not they stop working or need treatment. So now if you have fever or bloody diarrhea, and they use the word or, you should be evaluated for Salmonella enteritica subspecies, Shigella, and Campylobacter. And they want you to consider enteric fever, and that's just, for those of you at home who don't remember what that was, that's think typhoid fever from Salmonella typhi. If a person has exposure directly by travel or eating food by someone who just recently traveled. And they make that recommendation for anyone. Fever, bloody diarrhea, look for Salmonella. It seemed to me that that's a little too, I found that a little too all-encompassing. I guess you won't miss any if you do it that way, but there are, you can have some bloody diarrhea from rota or norovirus or something, or a viral cause. Am I wrong?
It's a great question. I usually think of a viral cause leading to bloody diarrhea as predominantly cytomegalovirus, particularly in those who are immune compromised, where CMV may be more predisposed to occurring. I usually don't think about rotavirus or norovirus leading to bloody diarrhea. There could be perianal irritation, which may cloud that picture. As far as your second point regarding the focusing on salmonella with regards to bloody diarrhea, one perspective that they may be approaching the situation on is what can necessarily be treated versus what can be perhaps detrimentally affected if there was actual treatment such as antibiotics for. And if there's systemic signs, they do suggest that antibiotic treatment could be useful for salmonella.
Yeah, we'll get to that. They talk about that if the person has systemic signs or if they're ill or immunocompromised, then consider treatment, or especially infants under 3 months old. We don't see a lot of those kids. I feel those kids are probably either more in the ICU or, for instance, if they're hematology oncology patients, immunocompromised because of chemotherapy, they're on hemonc service here. So we don't have a lot of the kids that come in who have bloody or prolonged diarrhea that we find have bacterial causes, for the most part, don't meet that criteria. We don't see a lot of them. But so now, speaking of which, let's talk about the indications for admission. This came from the Peds in Review article because this guidelines didn't really talk about it. And for those of you listening at home who take care of kids in the hospital, it's what you expect it to be. So intractable emesis, poor oral rehydration tolerance or refusal, severe dehydration with a loss of more than 9% of your body weight, young age, kids less than 1 year old, that's what they define it as, with irritability, lethargy, or an uncertain diagnosis that could require close observation, underlying illness that may complicate the course of disease like immunocompromise or anything like that, ORS treatment failure, oral rehydration treatment failure, including worsening diarrhea, dehydration despite appropriate administration, and then the most broad one, and the one I think we do use, concerns regarding adequate care at home by caretakers. So the family is in flux, they're moving, and the social situation, you're not really certain. That list seemed pretty straightforward, pretty all-encompassing. Those are the kids we'll admit just to make sure they get rehydrated in-house. The next point we're going to talk about is they discuss the factors clinical or epidemiologic associated with complications or severe disease. And these are what you'd expect them to be. Dehydration increases the risk of death in both the young and the old. And then if there's Shiga toxin producing organisms, epidemiologically, if they're in the area, that could be a cause of hemolytic uremic syndrome. And then post-infectious or extraintestinal manifestation, whether that's, in the last episode of the podcast, we talked about arthritis associated with some of these GI bugs, and they talk about other things that could be associated with it. So post-infectious extraintestinal manifestations. A lot of this was, I guess the guideline was written, and it's important, but a lot of it was somewhat obvious if you do this on a regular basis. And that's been the case with a lot of these guidelines. If you take care of kids in the hospital, some of what they have to go over is the more basic stuff because you have learners, you have trainees, you have people who aren't as familiar.
Right. I completely agree. And that's probably where the most data is underlying to reading the guideline statements.
Yeah. So then when should you send diagnostic studies and for whom? That's their next point. And they talk about stools testing for Salmonella, Shigella, Campylobacter, Yersinia, C. difficile, and E. coli, Shiga toxin producing E. coli, in people with diarrhea, with fever, bloody or mucoid stools, severe abdominal cramping, and tenderness or signs of sepsis. And bloody stools are not an expected manifestation of C. difficile. So that was surprising. The C. diff really doesn't cause, because we always say, oh, that's non-differential if you have bloody stool. But if they say it's really not.
It's more statistically, it's more of a rare manifestation of C. difficile, which is a really good point they make.
Okay. So if I guess for C. difficile, it's more voluminous diarrhea, and of course there's the smell that any nurse on the pediatric floor can pick up.
Precisely.
And then blood cultures should be obtained for infants less than 3 months old, or anyone when there are signs of septicemia, when enteric fever is suspected, immunocompromised, systemic manifestations, hemolytic anemia, or people who travel and contact people from an enteric fever endemic area. So they say for all those patients, send a blood culture. So your average typical kid with acute gastroenteritis, maybe they don't feel good, but they're not severely sick. They're not hypotensive. They're not in the ICU. You really don't need a blood culture.
Correct.
And we don't, because we rarely send them, so that's good to know that we're doing the right thing. They remind us to test for Yersinia in people, but especially school-age kids. Again, these guidelines were written for adults and pediatrics, so it's tough. I teased out what was really pertinent for peds, because this is a pediatric podcast. Kids with right lower quadrant abdominal pain that mimics appendicitis or have mesenteric adenitis, but also have gastroenteritis and bloody diarrhea. And Yersinia is something they really want you to test for. And the Yersinia we've seen, there's always those reported cases of where there was no diarrhea. The person just looked like they had appendicitis, and then they go in and it's not that. And I guess that theirs is hard to pick up.
Yes, and it's also apparently hard to pick up via stool testing too.
Yeah, well, it makes it more fun. Send for Vibrio stool specimen in people with large volume rice water stools who have exposure to salty or brackish waters. And I have to be honest with you, I forgot what brackish water is. I'm not a seafaring person, so I looked it up, and it's water that's saltier than fresh water, but not as salty as seawater, so in between. And then consumption of raw or uncooked shellfish or travel to cholera endemic regions within 3 days prior to onset of diarrhea. And that reminded me how quickly Vibrio comes on. 3 days is a specific number they use. So it's one of those things where it's done 2-3 weeks ago. It's very, very recently.
Right.
Now, if there's an outbreak, multiple people who share a common meal is their example. So a family at a picnic, and they all come in with acute gastro. Maybe they're all bloody, they're all sick. Then send broader set of studies to look for the culprit to figure out what is everybody's cause. And if your patient's immunocompromised and has diarrhea, you have a broad differential, and you have to include Cryptosporidium, Cyclospora, Cystiospora, Microsporidium, Mycobacterium avi, and CMV. And after reading this, I remembered in the U.S. the most common parasites we see causing gastro, and I think it can be acute, is Giardia and Cryptosporidium. And Giardia is really the one that we look for because we're Pittsburgh is interesting in that there's a city, and then surrounding it's a lot of rural area. There's lots of state parks, places for people to camp, fish, and stream. So we've seen Giardia here, and it's one of them, and we're similar to the rest of the U.S. population. If there's going to be a parasite, it's probably going to be that one. Is that right?
Exactly.
And then for uncomplicated traveler's diarrhea, they say diagnostic testing is not recommended unless treatment's indicated. And remember, traveler's diarrhea lasting 14 days or longer should be evaluated for intestinal parasitic infections. And then test for C. diff in a traveler treated with antimicrobial agents in the preceding 12 weeks. And then, of course, if it's prolonged, consider IBD and post-infectious IBS as well. And I guess the next time, what I'd like to do at some point is talk about, in the future, a chronic gastritis. We see some of that too, and they're the more complicated kids to manage, figure out what's going on. But while we're talking about what tests to send for, on my internal medicine training, one of the things we used to send a lot of, or at least send, is stool osmolality to help decide from infectious diarrhea versus other cause. I don't see us doing that a lot in pediatrics. Is that something that's done a lot of, or no?
The answer is unfortunately no. A lot of diarrheal causes, particularly infectious, lead to a mixed picture of osmotic as well as secretory diarrhea. So testing for stool osmolality doesn't really help differentiate how we're going to manage this patient. The causes for secretory diarrhea are extremely rare. And to be honest, if a patient is admitted, a nice, easy way to differentiate osmotic versus secretory diarrhea is to make them NPO for 24 hours on IV fluids and see if the diarrhea persists or not.
Okay. And then while we're on that line, one of the things they did discuss about sending testing for was stool leukocytes, stool lactoferrin, and then stool calprotectin. And they say they're not that helpful. And what I was always taught, again, this is more on the internal medicine side, maybe this is one of the areas where pediatrics and internal medicine are very different, is if you had stool leukocytes, you tested for it, and it was positive, you're almost assured it's an infectious cause of diarrhea. But they're saying it really doesn't help at all. Is that right?
I completely agree, and I think because the likelihood of an infectious cause of this diarrhea is rather high given the acute nature, it's not really helping you change your management plan.
Okay. And the calprotectin, there's not enough evidence or literature to say one way or another about it being helpful.
Exactly.
Okay.
In the acute nature.
Let's see. So then their next question is, when should we test for C. diff? And they recommend in kids older than 2 years old, and they said 2 specifically. And, I know in under 1, a child can have C. diff as a colonizer. But I guess between 1 and 2, they're saying maybe. So above 2, if there's a child has acute diarrhea and they've had antimicrobial use, or they're in a long-term care facility, or they have a family member who has just had C. diff because they're in a long-term care facility, or they're a physician or something like that, then you can test a 2-year-old. If the test is positive, that's more likely to be a real positive. Is that right?
Correct. What they're getting at is that adult colonization rates are reached around the age of 2. And that transition occurs between 1 and 2, and there's a question surrounding whether or not infants have the receptor for the C. difficile toxin, as well as their coexistent high colonization rate, which makes the testing in that age group not as helpful.
And they talked about, more than one stool specimen isn't helpful. And they began differentiating the types of C. diff testing. Toxin versus the toxigenic C. diff nucleic acid amplification test. And I remember we have, in the past few years, switched to the nucleic acid amplification. And is that a better test for C. diff?
So from what my understanding is, it is more accurate for C. diff.
So then we talked about calprotectin and the fecal leukocytes. So, and then the blood work that's recommended, both the Pediatric Review article and the guideline, they're first to be said for your average kid with acute gastroenteritis, no blood work's needed, which makes sense. If the kid looks good and they're just, it's day 1, it's day 2, they still look well hydrated, you stop the vomiting with something like Zofran or ondansetron, and they're able to hydrate themselves, they'll be fine. But for people with, unless you want to establish the etiology of enteric fever, or if you think it's a significant infectious diarrhea, they say maybe. But for people with post-diarrheal hemolytic uremic syndrome, a stool culture, then give the sugar toxin-producing organism. If you're considering this person may have HUS and need some blood work to prove that. They talked about hemoglobin, platelets, electrolytes, BUN, creatinine to detect hematologic and renal manifestations in early hemolytic uremic syndrome. And then a peripheral blood smear looking for red blood cell fragments if you suspect HUS. And it's they really stress that it's a part of the diagnosis. I have rarely sent it, to be quite frank, because if the patient has it, there's usually a lot more other symptoms I've had where I can make the diagnosis. But I guess if I'm on the fence, that's a great test to send down and look at.
I completely agree. And they also get at the fact that for mild to moderate cases of acute diarrhea, there's poor utility in testing for electrolytes or utilizing BUN, creatinine, or even urine-specific gravity for hydration status compared to clinician physical examination.
Yeah, that's surprising because the specific gravity I use frequently as a test for where the child is in their hydration status. And I know it's affected by if you're giving IV fluids, etc. But they say even without that, your exam clinically is better than that. That really did surprise me. I thought that was a very good test.
Yeah.
So I guess like any other test, you can use it to confirm what you already think you know. But on its own, I wouldn't. They don't recommend using it. Yeah, that's great. And then they talk about follow-up stool specimens and non-stool tests that should be performed in those people who have had laboratory-confirmed pathogen-specific diarrhea and who improve or don't improve the treatment. And they say follow-up testing is not recommended. An exception would be enteric fever based upon your local health authorities, what they want you to do. And because they may want to know another culture before, if a person works in child care or is a long-term care facility employee or a food preparer or a physician, let's say. And then they check with your local health authorities. And then for people who don't respond to initial therapy, then consider other things. They talk about like lactose intolerance, celiac, etc. And then non-infectious causes like IBD, IBS should be considered if you have a person who has symptoms lasting longer than 14 days. And that's really 14 days straight. So you as a GI specialist, if a kid has acute gastroenteritis, has a couple of days where they're fine, then gets it again over a few more days, you're not going to look at that kid as someone who's 14 days straight. You may wait to see what happens.
Exactly. And I start to wonder about whether or not this was actually an acute gastroenteritis, especially if it's spaced relatively close with the symptoms, and whether or not there are other non-infectious causes. For example, ingestion leading to similar symptoms too.
Okay. Now, empiric antibiotic treatment for kids with bloody diarrhea. This always comes up. Residents, students always have questions on this on rounds. And this is, they follow what I do, which is also, that's nice. So immunocompetent children, infants less than 3 months old with suspicion of bacterial etiology. And that we always call, whenever we have that case, we specifically usually will call our infectious disease colleagues because the kids at that 3-month borderline, they may be able to skate through without antibiotics. And we usually work with them on it. But people have traveled recently internationally with a temp greater than 38.5 Celsius, and they have signs of sepsis or early signs of sepsis. They recommend considering empiric antibiotic treatment. ill immunocompetent patients with fever documented in a medical setting, and abdominal pain, body diarrhea, and then bacillary dysentery. So frequent scant bloody stools, fever, cramps, tenesmus. They consider those patients to get empiric antibiotic therapy. And then what they recommend using is third-generation cephalosporins for infants and children, and anyone with neurologic involvement if they're a kid, or azithromycin depending upon your susceptibilities. Is that what would you agree with that?
Yeah, so I just want to clarify that statement. Are they stating that regardless of a stool culture result, that in those populations, empiric antibiotic therapy is warranted?
I think they say later on that you first get stool culture, urine culture, and blood culture, and then start empiric antibiotic therapy while you're waiting for your sensitivities to come back to narrow.
Okay.
That's how, that's actually 2 sections down, but that's what they said.
Okay.
So, and they would recommend, especially because if you have a kid who's septic or has bacillary dysentery, and I have trouble with that word, they want you to start antibiotic therapy. And honestly, if I have a kid coming from, I'll be honest about my practice. If I have a kid coming from international who's visited family or relatives internationally and has come back and is very sick, I would usually not go it alone. I'll usually call an infectious disease specifically for a hand, knowing that there may be parasitic or other organisms that can cause this that I may not be acutely thinking about, and they're always extremely helpful. So, and they'll usually help guide in terms of antibiotic treatment. But that's what they recommend, it was nice to have some type of structure to it.
Yeah.
And they also talk about if you have a patient with bacterial colitis and a bacteria that you know produces Shiga toxin, then you should avoid antimicrobial therapy, which we've always talked to our students about, residents about. And there's insufficient evidence to recommend treatment for bacteria that don't produce Shiga toxin, so it's not helpful, again, unless your patient's septic or very, very ill. Right. And then for prolonged watery diarrhea, should you treat? And they really say no. The exception may be people who are immunocompromised or young infants who are ill appearing. But the kid that's had watery diarrhea for 3 weeks straight, antibiotics don't help, which makes sense. That kid needs a workup.
Right.
All right, so then rehydration therapy. Now, this was something, I don't know, maybe it must have been newer than I remember, because I remember the oral rehydration solution. But there's this now reduced osmolarity oral hydration solution. And I tried to Google this, and they recommend this. This is the World Health Organization as first line for mild to moderate dehydration. And they still use the 3 categories, mild, moderate, severe. For those of you listening at home, in the Peds in Review article I talked about, they still have the table. This is back in 2011. They have the table differentiating mild, moderate, severe dehydration in gastroenteritis. It's table 2 on page 49 in the article. It's really nice. And it was a nice little review and reminder of it. But they say for mild to moderate dehydration in infants, try the reduced osmolarity oral rehydration solution as first line. And then they say consider an NG if the infant's moderate and can't tolerate it or just doesn't want to take it, as long as they have normal mental status. And I tried to look up the reduced osmolarity ORS, and I think that's Pedialyte. So am I correct there?
I believe so.
Because there's a couple, when you look at the World Health Organization website, they give you a formula to create it, which is nice, but then a couple of the websites said over-the-counter brands, and Pedialyte is one of them. So that's nice to know. And that's not the original oral rehydration solution. This is the reduced osmolarity, which was a news to me. And then, of course, IV fluids, isotonic, lactated ringers or normal saline, when there's severe shock, altered mental status, failure of oral rehydration therapy, or ileus. And in kids, they talk about in kids with ketonemia, so ketones, you may need an initial course of IV hydration just to get them to start being able to take oral rehydration. We see that a ton, where a child's in the ER, the parent swears they won't drink anything, an IV is placed, the ER attendings appropriately give 40 mLs per kg over 2 hours of normal saline, the kid perks up, and they start drinking like champs. And that's great, and it's nice to see it in print of what we've been seeing anecdotally.
Exactly. In
severe dehydration, they want you to stay on IV fluids until your patient's completely back to baseline. 100% altered mental status, hydration, everything. And once you rehydrate, they talk about beginning maintenance IV fluids and then replacing any ongoing losses in stools with oral rehydration therapy. So, and that's a change. When I trained, what we used to have is 2 sets of IV fluids running. We would calculate the loss, mild, moderate, severe. We'd have that going over a 24-hour period, and then the maintenance therapy going simultaneously all through the IV. And here they're saying, once you get them up and going, keep them on maintenance fluids and have them take oral to keep up with their losses. And that's what we recommend now, right?
And I'm in the same boat as you, and my training was a lot different from what they're recommending now too.
Yeah, things are changing. They change regularly. The diet. Now, this was a change because we have for years heard about the gastro diet for kids with acute gastroenteritis. I believe at one point it was recommended by the AAP. And now they say, first of all, for breastfed infants, continue breastfeeding, that's fine, which was always the case. And then they say for kids otherwise, resume age-appropriate usual diet during or immediately after the rehydration process. Now, I always tell parents, this is not the time to go to Wendy's and get the 4 for $4. Avoid the real heavy, greasy foods, but whatever they would normally eat, if they want to eat it, let them eat it. And that's what they're saying here. Right. So the gastro diet's we no longer have to do it.
Exactly. It's poor utility.
And then ancillary treatments, and this was a big thing, anti-motility drugs, because there's really separate recommendations for adults and pediatrics. Adults, they say, sure, go ahead, unless there's worry about toxic medical or something. For kids, they say under 18 years of age, they recommend you do not give kids anti-motility agents for acute diarrhea. They talk about loperamide specifically because it's known to cause ileus and drowsiness in kids younger than 3. So really don't use it. And then even something like bismuth subsalicylate, which is another antidiarrheal med, in large quantities, it can lead to salicylate toxicity. So don't use it for that reason, right?
Exactly.
And then for anti-nausea, antiemetic agents, the most common is ondansetron or Zofran. You can give it, but they say to kids older than 4 to facilitate oral rehydration. But I've used it in kids younger than 4, calling our clinical pharmacist for help in terms of dosage and guidance for 1 dose to get a kid who's obviously having gastro and throwing up to get back in to drink again. Right. That's reasonable?
I think that's quite reasonable. The only thing I'll additionally add about loperamide is it's anti-diarrheal, but in the setting of an acute gastroenteritis type picture where there is clearly nausea and vomiting associated with it, loperamide can cause nausea too, which is another reason why it's not recommended.
Oh, yes, sir. Okay. Now, probiotics is the next thing they bring up, and this was great because, if you go to any drugstore, probiotics is an entire aisle. And now, for kids and for adults, they make it in gummy bear form, which is delicious and great. And I still use it for, if I'm giving a child ampicillin unison, I can't think of, or augmented, moxicillin clavulanic acid, that's the name of it. And I know they're going to get some diarrhea from the antibiotic. I'll give them probiotics. I think that helps. Evidence is mixed on that. In the guidelines, they say go ahead and try it. But recently, since the guidelines were produced, in this past year, 2018 in November, we had a journal club within our division, and Dr. Sarah McIntyre presented these 2 articles in the New England Journal of Medicine, November 22nd, 2018. Both were randomized, double-blind, placebo-controlled trials. One's titled Multicenter Trial of Combination Probiotic for Children with Gastroenteritis. One is Lactobacillus rhamnosus gastroenteritis versus Lactobacillus rhamnosus GG versus placebo for acute gastroenteritis in children by David Schnadover et al. Is the second one. The first one, Stephen Friedman et al. And they both showed, these were the studies done in Canada, there was absolutely no difference. If you gave the kid big doses of probiotics or not, it doesn't change anything in terms of the length of gastroenteritis, the complications, potential need for IV, for any type of readmission for it. Changes nothing. So they don't think it really helps, very helpful. And those are 2 separate articles. And they were well done studies. So I kind of believe them. So while there's probably no harm in doing it, I don't think it's necessary to try it.
Exactly. And that's contrary to what we traditionally thought based on the retrospective studies, where they thought it would decrease illness duration. Right. Particularly lactobacillus.
And that's sad because it's such an easy thing to give, but there is a cost associated with it. I mean, these companies they do cost something. So we'll see. Then the zinc treatment, they recommend it in kids 6 months to 5 years only if you live in a country with a high prevalence of zinc deficiency. And I don't think we have any deficiencies in the country besides vitamin D.
The only thing I'll just add to all this is it's really helpful that these background studies have been done, because it's really hard from a patient and family perspective to have an acute gastroenteritis and being told, guess what, just let it go.
Yeah.
No pun intended. But it's our human nature to try to act, to try to fix. And it's really, really difficult to just support. Yeah. And everything that you are reiterating is more supportive in nature. But it's also helpful to keep in mind, even though our instinct is to try to do, it's also do no harm. So and aside from probiotics, which I completely agree with your point, there are harm in a lot of the other interventions you mentioned.
So along the pun line, let's do everyone who listens to this podcast know we have a corny joke segment, and we'll do it now to kind of interrupt what we're doing for the flow. So I'll do the first one, and you're welcome to do one, Arvind, if you'd like. I'll start with the first one. So why was the leopard so bad at playing hide and seek? Because he was always spotted.
So Tony, what starts with an E, ends with an E, and only has one letter in it?
I don't know.
An envelope.
And the last one, this is my favorite. What do you call a row of rabbits hopping away? A receding hairline. Do love these. All right. So we're rapidly getting towards the end here, which is good. We're making pretty good time. So what about, they begin talking about asymptomatic people with an ID bacterial organism, so you know what it is, via stool culture or molecular testing. What do you do for those people? So if they say if they practice good hand hygiene and they live and work in a low-risk setting, they don't provide health care or child or elderly care, they're not food service employees, they don't need treatment unless you have Salmonella enteritica. If they live or work in a high-risk setting we talked about, they should be treated according to their local public health guidelines. And every state, every county could be a little different. So those you have to look up. The rest, they talked about washing your hands, which at this point in medicine, we all know that's good. And then using contact precautions if you go in a room with a patient who has acute gastroenteritis, especially bloody diarrhea, and appropriate food safety practices for whatever your state or county recommends. Then they begin to talk about vaccines. And the rotavirus vaccine, we kind of talked about how helpful it's been. But there apparently is 2 typhoid vaccinations which are recommended and they talk about this as adjuncts to hand hygiene and avoidance of high-risk food and beverages for travelers if you're going to an area where there's moderate to high risk for exposure to Salmonella enteritica. I found it interesting that they said it that way. It wasn't, you need to get this if you go. It's an adjunct to doing all of this stuff to help prevent Salmonella enteritica.
Right. I agree.
So that was acute gastroenteritis. That's everything I got from the guidelines, and then the important parts I thought that came from the Peds in Review article. From your perspective, Arvind, do you, as a gastroenterologist, do you get a lot of consults for kids who come in for acute gastroenteritis?
Not really. I think given logistics of wait times and such, those patients have typically gotten better by the time they've arrived to our clinic. So
rare, and even on the inpatient setting, you really don't get called a lot for the bloody diarrhea, etc. You probably get called more for the chronic diarrhea. Exactly. Which we're going to have to get to in another segment, because that's something, again, that becomes more of a problematic issue. The acute is pretty straightforward. It was nice, I thought, to review some of the more rare Yersinia, Salmonella enteritica, the typhi, subtype typhi, what to think about for C. difficile. They didn't talk about C. diff treatment, but I would stick with the usual flagyl, then vancomycin for pediatrics. Is that correct?
Yeah.
Oral vancomycin?
Exactly. Flagyl, then oral vancomycin is your typical steps.
And I know there's some stuff being done in terms of looking at C. difficile, if it's changing, if we have to move vancomycin up from the third round to second or first round. Do you know if anything's been published recently that's interesting to that effect, or still just work being done?
So there's been suggestion in the GI literature for conditions, namely inflammatory bowel disease, which could be co-infected with, not co-infected, but infected with C. difficile, that vancomycin may be more helpful. But to summarize, it's more certain populations.
Okay. So, if you're listening at home, folks, this is one of our shorter podcasts. We got it down in about 45 minutes, which isn't bad. A lot of ours have been over an hour, so it's nice to have one that's a little bit shorter. So, I want to wrap up by thanking my guest again, Dr. Arvind Srinath. Arvind, thank you for joining us. We really appreciate it.
Thank you for this opportunity.
All right, everybody, time for our acknowledgments. I want to again thank our special guest for being here. Really appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast, the University of Pittsburgh for continuing to give us free CME credit and support the podcast. And just as a reminder, all you have to do is go to the link in the description of this episode, click on it, put in a free username and password, answer some easy questions. You get free AMA Category 1 CME credit courtesy of the University of Pittsburgh. I want to thank Dr. Megan Helen Keene Tarchichi, who always helps me with everything. I want to thank all of you who are listening. Thank you very much for taking the time out, listening to us, letting us come into your ears or in your car or wherever you are. All right, everybody, we'll see you next time. Everyone be safe.